Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a topic on anatomy, and our topic is Anatomy of Tonsil. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. Now, as we know, tonsil, which is also known as palatine tonsils, these are two in number, lying one on either side of the body. Now, if we had to look where is the location of the tonsil, let's look at the image over here. What we are seeing here is this is the lateral wall of the oropharynx. This here is the anterior pillar which is formed by the palatoglossus muscle, and this here is the posterior pillar which is formed by the palatopharyngeus muscle. So, our tonsil lies in between these two pillars, the anterior pillar and the posterior pillar, which is formed by these two muscles in the lateral wall of the pharynx, and in between this lies the tonsillar bed. So, that is where the tonsil is located, and the tonsil is surrounded by a tonsillar capsule. Now let's talk about the size of the tonsil. So the size does not remain constant as we keep aging. It is actually very variable and it keeps changing depending on the age of the person as well as the pathological status of the person. So first let's talk about the age part. So the size of the tonsil starts increasing very rapidly around the age of 5 to 6, and then it reaches a maximum age during a maximum size during the time of puberty, after which it starts involuting. So that is the relationship of the size of tonsil as we keep aging. And by the time a person is very old, very little lymphoid tissue is left behind in this region. So, if I think you know about this already, the tonsil forms a part of this lymphoid tissue ring that is located in the upper aerodigestive tract, which is known as the Waldeyer's ring. You can check out my video on Waldeyer's ring to know more about this. So the tonsil basically forms this first line defense system of the body as a part of this Waldeyer's ring. Now, we were talking about the size varying with the pathological status as well. So, if we see in a case of acute tonsillitis, we'll see that the tonsils are much enlarged at that time. Whereas, maybe in a case of chronic tonsillitis, you may find your tonsils to shrink and become very fibrous. So, the size of the tonsil keeps varying according to the age of the person as well as what is the pathological status of the person. Now, talking about shape, if we look over here, we can see that the tonsil is looking like this ovoid mass. So, it is this ovoid mass of lymphoid tissue which forms a part in the Waldeyer's ring. And this has a very fixed position. So, you can see in the image here that the long axis of the tonsil lies in this superior to inferior direction. So this is the location of our tonsil. Now let's talk about what are the different parts of tonsil and what does each part contain. So if you look here, this here is the upper pole, this here is the lower pole. So a tonsil has two poles, upper and lower pole, and it has two surfaces, the medial surface and the lateral surface. So these are the four parts of the tonsil. Let's discuss each one of them. First, if we look at the upper pole, we can see in the image here how the upper pole is extending towards the soft palate over here. And the medial surface of this upper pole gets covered by this semilunar fold, which extends in between the anterior pillar and the posterior pillar, and this semilunar fold encloses a potential space in between it, and this space is known as the supratonsillar fossa. So that is about our upper pole where it is extending into the soft palate, and in the medial surface it gets covered by a semilunar fold, and the space within this is known as the supratonsillar fossa. Next, looking at the lower pole, this gets attached to the tongue, and a triangular fold of mucous membrane here also extends from the anterior pillar and it reaches to the anteroinferior part of the tonsil. And the space that is getting enclosed over here is known as the anterior tonsillar space. And lastly, the tonsil in its lower pole, it gets separated from the tongue by a sulcus which is known as the tonsillolingual sulcus. And this sulcus, a clinical importance over here and applied anatomy point over here would be that this tonsillolingual sulcus can actually be the seat of carcinoma in patients. Next, moving on to discussing the medial surface. Now, the medial surface is very important. So, first of all, the lining, the epithelial lining of the tonsil on the medial surface is a non keratinizing stratified squamous epithelium. And this epithelium, what it does is, let's look at our image over here. It dips into the substance of the tonsil. And as it dips, it creates this crypts within it. Now, we have a lot of crypts which open into the medial surface over here, about 12 to 15 crypts open into this surface. Now, out of all these crypts, there is something known as the crypta magna. This is one crypt which is seen mostly in the upper part of the tonsil, which, as you can see in the image here, is very large and very deep. Therefore, this is known as the crypta magna, also known as the intratonsillar cleft. What is the importance of this crypt? This crypt represents ventral part of the second pharyngeal pouch. So now we have discussed all these crypts. Now from these crypts, a lot of secondary crypts also keep arising. So we can see that this is a primary crypt, this is a primary crypt. So we can see 4 primary crypts over here. But as it dips into the substance of the tonsil, a lot of secondary crypts also keep arising from the primary crypt within the substance of the tonsil. And when the tonsils get infected in tonsillitis, these crypts can actually get filled with cheesy material. And this cheesy material is usually a combination of the epithelial cells, the bacteria, and food debris which can get accumulated over there. And this cheesy material can be expressed out if you apply pressure on the anterior pillar. So, a primary important part about medial surface is knowing the crypts over here and how these crypts can get accumulated with certain material, leading to this cheesy appearance. And when you press on the anterior pillar, in case of a tonsillitis case, these cheesy material can get expressed out. Lastly, is the lateral surface. Now, this lateral surface, which is this side, the lateral surface is covered with a well defined fibrous tonsil. Between the capsule and the bed of the tonsil is a loose areolar tissue. And this areolar tissue is the plane of dissection where we perform tonsillectomy. And this loose areolar tissue, this area is known as the peritonsillar space. Let's look at the image over here. This is the capsule of the tonsil, and this space that we are seeing over here, this is the peritonsillar space. And this peritonsillar space consists of loose areolar tissue as well as the paratonsillar vein. So this area, this plane is the plane of dissection when we are performing tonsillectomy. And also in cases of peritonsillar abscess or quinsy, I have a video on this where I explain more in details about what happens in peritonsillar abscess. So this is the site for peritonsillar abscess formation. So this is all about the different parts of tonsil. Now let's discuss a very important part, which is it is a viva question as well as it can be a short note in your theory questions. What are the structures of the tonsillar bed? Now, I have a separate video on this where you can check it out, where I tell you a very easy way to remember the different structures of the tonsillar bed in order, one after the other in a particular direction. But let me talk about it in a little bit over here as well. So, all the lateral relations of the tonsillar bed are, first of all, is our tonsillar capsule. Then, lateral to it lies the loose areolar tissue which contains the paratonsillar vein. Then, we have the pharyngobasilar fascia, which is this green structure. Then, we have the superior constrictor muscle over here, lateral to which lies the buccopharyngeal fascia. Then, inferiorly, we have the styloglossus muscle over here, and around the styloglossus muscle is the glossopharyngeal nerve. We also have the facial artery coming in around this area and giving branches to the tonsil bed, to the tonsil. And after this, we have the medial pterygoid muscle, which lies here, the submandibular gland, which lies here, and lastly, the most lateral structure is the angle of the mandible. So, these are all the structures of the tonsillar bed, and you should remember exactly in this order, which is from medial to lateral direction. You can check out my video where I talk about a very easy way to remember all the structures in the tonsil bed. Next, moving on, let's talk about the blood supply of the tonsil. Now, coming to blood supply, it's divided into arterial supply and venous drainage. Now, let's look at the image over here. So, first of all, if you remember the artery, this is the external carotid artery, and the external carotid artery goes up and it terminates in two arteries, which is the superficial temporal artery and the maxillary artery. So, now all our branches are going to come from this external carotid artery. So, this external carotid artery, one of the branches that come from it is the ascending pharyngeal artery. This ascending pharyngeal artery gives some tonsillar branches to the tonsil. Next, we have the lingual artery, which is a branch of the external carotid artery. And this lingual artery gives off these dorsal linguae branches to the tonsil. Third artery is facial artery. Now, facial artery is also a branch of the external carotid artery, and here facial artery gives off two different branches to the tonsil. What are these two different branches? One is the tonsillar artery, and second one is the ascending palatine artery. Out of this, the tonsillar artery of the which is a branch of the facial artery is the main arterial supply of the tonsil. Other than this, the last branch comes from the maxillary artery, which is known as the descending palatine artery. So as you can see, we have five arterial branches over here. The main one being tonsillar artery, which is a branch of the facial artery, and this gains access to the tonsil after it penetrates the superior constrictor muscle. And as you can see in the image over here, it enters through the inferior pole of the tonsil. Second, we have the ascending pharyngeal artery, which is a branch of the external carotid artery. Then we have the ascending palatine artery, which again is a branch of facial artery. Then we have the descending palatine artery, which is a branch of the maxillary artery. And last of all, we have the dorsal linguae branches of the lingual artery. So that's about our arterial supply. You can check out my video on the blood supply of tonsil where I talk about a mnemonic on how to easily remember all these branches, because this is a very important Viva question that you'll indefinitely be asked if you get a case of tonsillitis. Next, looking at the venous drainage. So, the venous drainage over here is via plexiform arrangement, which lies deep to the tonsils via the pharyngeal venous plexus. And there is a vein which is known as the external palatine vein. Now, external palatine vein is just another name for the paratonsillar vein. We saw how the paratonsillar vein lies in the loose areolar tissue, which lies lateral to the capsule. So the area, the plane of dissection for tonsillectomy, that area is where the paratonsillar vein lies. And this paratonsillar vein is the most common structure to be responsible for causing post-tonsillectomy bleeds. So all the veins from the tonsil, it drains into this paratonsillar vein, and then the paratonsillar vein goes and drains in the common facial vein, which ultimately drains into the pharyngeal venous plexus. Next, let's look at the lymphatic drainage of the tonsil. Now, all the lymphatics from the tonsil, they end up piercing the superior constrictor muscle, which is the structure of the tonsil bed, and then it goes and drains into the upper deep cervical nodes. Out of this upper deep cervical nodes, the most prominent one is the jugulodigastric node, which lies just below the angle of the mandible. Next, let's talk about the nerve supply of the tonsil. So, tonsils get their nerve supply from a tonsillar plexus. Now, this plexus is a meshwork of nerves which is originating from the tonsillar branches of the maxillary nerve and the glossopharyngeal nerve. Fibers coming from the maxillary nerve, they get distributed into the lesser palatine nerve, and via this They combine with the glossopharyngeal nerve and then they form this plexiform arrangement that we are talking about. So that's about a nerve supply. This nerve supply has an importance in our applied anatomy, which I'll talk about in a little bit. Lastly, what is the function of tonsil? As I mentioned before, the tonsil forms a part of the Waldeer's ring. The image over here, you can see this is what the Waldeer's ring looks like, and this provides first line defense to the upper aerodigestive tract. They act as sentinel lymph nodes to guard, not sentinel lymph node, I'm sorry. They act as sentinel to guard against the foreign intruders like any viruses or bacteria or any other antigen which is coming into contact with the aerodigestive tract through inhalation and ingestion. So it forms our first line defense system of the body in the upper aerodigestive tract. So that's about our function of tonsil. Lastly, let's discuss a few points about the applied anatomy of tonsil. The first one is referred ear pain and tonsillitis. So, if you remember when I was discussing about the nerve supply, I mentioned that it has a nerve supply coming from the maxillary nerve and the glossopharyngeal nerve. Now, here in the middle ear, it is gets its nerve supply from the tympanic branch. It gets its nerve supply from the tympanic branch of the glossopharyngeal nerve. So you can see how the tonsil and the middle ear they have a common blood supply, so a common nerve supply coming from the glossopharyngeal nerve. And that is the reason why there is a referred pain in the ear in cases of tonsillitis because of the same innervation by the same cranial nerve. Second is peritonsillar abscess. I discussed about the peritonsillar space which lies lateral to the capsule of the tonsil, and that space is where the peritonsillar abscess develops, which is also known as quinsy. And when there is a peritonsillar abscess, usually we drain it by giving an incision in the most prominent bulging part of the collection. Third is post tonsillectomy bleed. Again, I've already discussed about this. The paratonsillar vein, which is also known as the external palatine vein, this lies in the loose areolar tissue lateral to the capsule, and this is the most common reason for a post tonsillectomy bleed. And lastly, another important feature that we should know is the internal carotid artery. It lies 2.5 centimeter posterolateral to the tonsils. So that's about our applied anatomy. And that finishes our discussion on anatomy of tonsil. If you have any further questions, please note them down in our comment section and I'll get back to you. Thank you.